Telugu channel. I'm your host, Varsha Singh, and once again, I'm here today with all of you to talk about something that's very important to all of us. Yes, you guessed it right. Today, I'm going to bring some more medical information, health information, which will help all of us to improve the quality of our life. How do we improve quality of our life? By taking care of ourselves. If we have any condition, any physical or mental condition, then we must know what we can do to get the right treatment, how to prevent it, and how to take care of ourselves so that we can enjoy our life every day. Today's topic is equally important, like all other topics that we have discussed earlier in our earlier episodes. So thank you for watching them all the time and being loyal to Healthline on TVAsia Telugu channel. So the topic of today's discussion is migraine. And my first question to Dr. Sathe would be, what is migraine? And how is it different from any other type of headache?
So as you pointed out rightly, Varsha, migraine is a headache disorder. In fact, it is the classic or prototypic headache disorder. And what distinguishes it from other headaches, so to say, that it is an episodic headache condition. You rightly said that it probably affects at least 1 in 6 people in this world. There are some diagnostic criteria laid down for migraine. The headache could be unilateral or bilateral, but it has to have a throbbing character, right? It has to be at least of moderate to severe intensity, and it usually gets worse with activities of daily living. And you would have to meet at least 2 of these criteria considered for the diagnosis of migraine. And then at least 1 of the associated features has to be present. So there either has to be nausea or vomiting, or both, or sensitivity to light or sound, or both. So one of the features at least has to be present. So if we find these features in somebody presenting with headache of episodic nature, then we consider the diagnosis of migraine. And I would like to offset those numbers a little bit. Although it is true that 1 in 6 people probably have migraine, a lot of them have a very mild kind of migraine, and they kind of have identified it, they recognize what triggers it, and they take care of it by themselves, either by over-the-counter medication or just relief measures such as lying in a dark room, sleeping, whichever helps them, or maybe a couple of cups of coffee, whatever helps them. So a significant number of people may not end up seeing a doctor for migraine. They have migraine and they're taking care of it. Which is fine. I'm not recommending that they all go to the doctor. But there is a whole bunch of people who have very mild migraine in their life.
So Dr. Sathe, question is, how common is migraine? Who can get it? Is there a particular age group, or is there a particular gender? Do men get it more than female? How do we explain that?
So we rightly said that migraine probably affects 1/6 of the world population, and a majority of those cases are mild. They don't end up in doctors' offices. The fact that a person seeks medical advice for headache is already indicative that it is probably at least a moderate disorder that the person cannot manage on their own, and that's bringing them to the doctor's office. Usually the onset of migraine is in the teens or maybe early 20s. That's when we see the first occurrence of migraine, so to say. It is much more common in women than it is in men. If somebody starts presenting with, say, headache in their 50s or 40s and never had a prior history of headache, it would be difficult to label them as migraine. That would entail some investigation, making sure that it is not some other kind of headache, something more concerning. It's not impossible, but it's difficult to label somebody just migraine when the presentation is not consistent with their age.
Wonderful. Thank you so much for sharing that and clarifying that migraine is not a typical headache. It has aura, it has a typical symptom set, So I wanted to ask you again, is there any type of migraine or all migraine headaches are same?
But migraine largely has two kinds. One is migraine with aura and migraine without aura. The migraine with aura is indicative that there is a premonition or a warning for the patient or the person that they are about to get a headache. Now, this warning very often could be just in the form of nausea, or sometimes even vomiting. There are other auras as well. The most famous aura of migraine is a visual aura, where people see bright lights and scintillating lights. There is a whole description of migraine aura in neurology. There are some smells that people can get as an aura. And usually with the resolution of aura, the headache starts to become more intense or starts to begin. Migraine with aura is probably less common than migraine without aura. And in certain conditions, this aura can really be complicated. There are certain inherited conditions as well as non-inherited, where these auras could be more complex, such as difficulty speaking or weakness of the arm, weakness of the leg, weakness of whole side, and so on. Fortunately, that's uncommon, as well as the fact that they do recover when the headache goes away. So these are not permanent deficits, but it's certainly very scary to the patient, especially the first few times when they get it. They're all of a sudden now they have speech difficulty or their arm is not moving in association with the headache.
The way you are explaining, migraine is not a very straightforward, typical set of symptoms. It can have a variety of presentations. And as a neurologist, I'm just trying to decipher your message that instead of getting worried or, because you mentioned that there can be a weakness of the leg, weakness of the part of the body, they definitely need to consult if these symptoms are repeating themselves. And that brings me to the question, because many people might be experiencing headache of different kind. So in order to have a diagnosis of migraine, there is a particular way to diagnose migraine. So if you can explain how you make the diagnosis of the migraine.
So migraine is a clinical diagnosis. There is no test that can establish that this is migraine. We always look for the history. Like I said, the criteria that we look for, that we discussed before. But more importantly, certain situations, I would say, migraine could even be a diagnosis of exclusion. Because migraine in itself does not cause any brain damage per se, right? We do not expect any neuronal loss or any neuronal injury after an episode of migraine. Whereas we want to make sure that the headache that the patient is presenting with is not of some other kind, which of more concerning kind. And the whole investigation will be diverted towards that. Now, again, it depends on the presentation. If it's a young person, presenting with the classic syndrome, a classic symptom, episodes of migraine, somebody in their early 20s, the confidence associated with diagnosis there's a lot of ease and a lot of certainty with the diagnosis. If there are features that are, if it's a new onset headache, it is getting worse by the day, those kind of things would make one wonder if it is not migraine. In that situation, we would recommend workup, like say most basic workup would be a brain MRI these days, or other blood tests and so on, depending on what the underlying suspicion is. Migraine headache is inconsequential. That's my term, meaning that a person might get as many episodes of migraine in their life, but it would really not have an impact on their brain per se. So there's no consequence to the brain, if you would, from having attacks of migraine. And the purpose of an evaluation is to make sure that that's what it is, that it is not a consequential disorder where you expect some brain injury or brain damage, and you want to rule that out before you establish a diagnosis of migraine.
Yeah, I recall from your last presentation that you had mentioned that brain actually does not feel pain. So whatever pain a patient is feeling while having migraine is in surrounding the brain and not actually causing any neuronal damage, as you mentioned. So you did mention that part of the evaluation is MRA. So are there any other evaluations when a patient is presenting with symptoms of migraine? Do you conduct any other test, or are there any other evaluation that you do?
No, we would not even consider doing MRI in every patient. It really depends on who the patient, the age of the patient, the background of the patient, and so on. If the clinical suspicion is very, very strong for just either migraine with aura or migraine without aura, MRI may not always be recommended. Though I see that migraine with aura probably in today's day and age, an MRI is strongly considered. When it is not in that very classic situation or classic symptoms, then we would consider other tests. So some of the other disorders that we would consider are, say, for example, inflammation of the blood vessels, what is called vasculitis, or in rare situations, even a brain tumor. So it all depends on what the patient is telling us regarding the onset and progression of the headache, and we will make a decision accordingly.
Thank you, Dr. Sathe. So the next thing that I would like to discuss in this on this topic is it possible that the presentation of migraine can change? It may not stay the same, and the symptomatology may change their nature.
It does happen very often, Varsha. So as people get older and are faced with various stresses of life, and their situation changes, migraine very often will get more frequent or more intense, or both. And a number of times what happens is individuals have not sought medical attention early in their 20s when they were able to manage their migraine by themselves. But as it becomes more frequent and more intense, then that's the time that they present to a physician's office. So then it's important to make sure that we establish that previous history, that there was a headache disorder before and just has become more intense and more frequent now, and that we are not dealing with some new kind of a headache at that time. So just as migraine is a spectrum from mild to severe, like we said before, there are a number of people probably don't seek medical attention for migraine. It's also a spectrum from episodic to chronic. When that happens, when the migraine of being episodic occurs more and more commonly, then we sometimes call it as transformed migraine. And then we would say something, we would call something chronic migraine if a headache occurs on more than 15 days of the month. And at least 8 of those days, the character of the headache is the same as it was for the previous migraine episodes. And then in that situation, the evaluation changes or the management of migraine changes when this kind of transformation occurs.
Yeah. So when you said management, I think that's where we are heading now. Because migraine can be really disabling for some people. It can make a person completely non-functional, and we know that it is a most common neurological disorder. So we will. I would like you to say a couple of things about the management. What is the most common treatment right now, and then as we go further discussing the management, I would like to also ask what is the most commonly given treatment, and if there is anything new that is in the market, how the management is decided, and what is the typical management of migraine?
So the management of migraine is entirely dependent on the frequency and intensity of the headache. For patients or individuals who can manage their migraine by taking few pills of ibuprofen or any other over-the-counter medication, well, that is the recommendation. We don't really want to change it. Some people know their definite triggers, lack of sleep, if they stay hungry for a period of time. Red wine is classically known as a trigger. Chocolate used to be known as a trigger. Ajinomoto, which is a dietary enhancer of flavor.
Taste enhancer.
Taste flavor enhancer, which is very commonly used in Mexican food as well as Chinese food. That's a known trigger for migraine. So a lot of individuals know their triggers, and they have learned to avoid them or take care of them as the situation may be. A lot of times rest will relieve the headache. A couple of cups of coffee will relieve the headache. So if all of that is known and that's what the individual has been doing, we recommend to continue that. Wouldn't necessarily change management at that time. Very often if they come to the office, that means all of these measures have failed, and that's why we are seeing them. So there are the migraine management can be classified as either an abortive therapy, meaning medication that is to be taken during the headache or at the onset of headache to stop the attack, to make the attack shorter, and preventative medication, which we would use if we want to reduce the number of attacks that the person is having, say, per month. For abortive therapy, as we said, over-the-counter pain medications, whichever work. If not, there are a few that are specific for migraine, so to say. In the past, there used to be medications called ergot derivatives that we don't use a lot any longer. But those were specific for migraine. They did help with migraine attacks, but the side effect profile was not very favorable. Then there is a medication called Fioristat or Fiorinal, as the trade names are in the US. And they are a combination of acetaminophen with caffeine and butalbital. And though these are pretty, so the caffeine is in a much stronger strength than what we would get in a cup of coffee. These combination medications have always been proven to be very useful for stopping a headache attack. The most important thing about taking these kind of medications is the recommendation is to take them as soon as possible. We do not recommend that the attack be continued to be a full-blown migraine, with nausea and vomiting, and then take the medication. If the person knows that the headache is coming on, they should really try to take the medication sooner rather than later. They can repeat a dose of these medications in a few hours if the headache is not gone away. And then there's a second group of medications which has been around, I suppose, for more than 15 years now, called the triptans. And again, they are migraine specific. They don't work on any other kind of headache. Same recommendation to be taken sooner rather than later in a headache attack. So we recommend these medications as abortive therapy. In general, we do not recommend taking these medications, say, more than 2 or 3 times a week. And in fact, a lot of prescription for triptans will only have 9 pills in a month. And the idea is that if someone is requiring more than 9 pills of triptans a month, then there has to be a change in strategy of migraine management. And that brings us to the preventative therapy. So if somebody is requiring these kind of medications more frequently, we would want to give them something on a daily basis to prevent these attacks of headache from coming on. A number of patients do not like this idea of taking some medication on a daily basis, because if the headache is episodic, why is the medication daily? And we really have to do a little bit of a risk benefit. But truly, if somebody is requiring medications more than 2 or 3 times a week, it may be a good idea to consider preventative medications. These preventative medications for migraine come from various classes of drugs, really. And they have often been found to be useful for migraine as a afterthought or an after fact. The medications are used for some other reason, and then patients have reported that their migraine is getting better, and that's how they got established as migraine therapies. Not many of them were tried as prospective, developed for specifically for migraine, except the new drug that we will talk about shortly. So these medications come from various classes. Historically, or the oldest ones are beta blockers, which are cardiac drugs really used for high blood pressure and other kinds of heart disease, work very, very well for migraine. Then there are a group of medications called tricyclic antidepressants, which are again very old medications used for anxiety and depression. They have proven to be helpful in migraine. I cannot name all of them because there is a whole bunch of them. Gabapentin is another one, which is an anti-seizure medication. In fact, there are several anti-seizure medications that have been used in migraine, and they have proven to be useful. We don't quite use them at the same dose as we would use them for seizures, but lower doses in most cases. And so because of this very wide range of medications that are available, we always like to personalize it or customize it, so to say. And if we can use a medication for 2 things, then of course we would like to do that. So, we would always want to use beta blockers if somebody's already using them for, say, high blood pressure. Anxiety and depression are known comorbidities of migraine. And if we can use tricyclics in that way, we would try to, treat 2 disorders with the same medication. So there's a lot of room for personalization. Or sometimes we don't want to use certain drugs, say in childbearing age group or in asthmatics and so on. So we personalize the therapy as much as we can till the headache is at least controlled reasonably, and then we can try to taper them off. But this preventative therapy takes a while, at least depending on each person. So I don't want to really give just a random timeline, but at least months to years to stabilize the patient, and then it can be withdrawn.
Dr. Sathe, we talked about the preventative and over-the-counter medications that can be used to manage migraine. what is the most new age medication that is in market nowadays? Because in media, there is a particular medication which is advertised very extensively. If you can talk about that.
So the new medications for migraine, which probably have come in the past 3 years or so, I think there are 3 now approved medications, and these are calcitonin gene-related peptides. These are short chain of proteins. There was research to show that calcitonin gene-related peptides, CGRP, is released during an attack of migraine and continues to be released or is, persists, so to say, during the whole episode or even beyond it. And these peptides really, the compound or the drug that we are talking about is GCRP antibodies. So these are monoclonal antibodies, genetically engineered to be given as infusion, usually say every 4 weeks or so, that go and block this protein. They were initially thought that they would be a abortive therapy, but what they did turn out to be is preventative therapy. And in terms of being migraine specific, we can say that these are the first migraine specific compounds that have been developed and approved. We still are seeing how much benefit they will offer because the data is still limited only over the past 2 or 3 years or so. But the one other medication that we didn't talk about is botulinum toxin. We all know that botulinum toxin is used for cosmetic purposes, but again, the same principle that individuals reported that when they took botulinum toxin for cosmetic purposes, their migraine got better. And then there were prospective studies looking at the efficacy of botulinum toxin. It did turn out to be efficacious, and so it's now approved as a preventative therapy for migraine. So those are kind of the whole gamut of medications, from over-the-counter nutritional supplements to, say, medications, non-medical therapies, and now the 2 injectables. Botulinum is local injection. This is an IV injection for prevention of migraine. So we have a whole battery of things that we can use.
So we have like the whole range and a lot of options, which is a good thing. That the patients now have a choice from this, whichever spectrum they are at, mild to severe. There are a lot of options available, and it's really a great knowledge that is being shared with our viewers that just go out there, and if anyone is suffering from migraine, even if it is mild, don't wait for it to become severe. At least have a conversation. That's what we are actually trying to send the message to our viewers, that if you think that you have a particular condition such as migraine, then it doesn't hurt to talk to the physician, talk to the primary, and then seek out which kind of management helps you. So Dr. Sathe, as we go further talking about the management of migraine, I wanted to ask you, this is a burning question. You talked about the patients that sometimes they do not like that daily preventative medicine, but there are also patients who are taking too many medications to treat their migraine. So what is the impact of taking too many medications if they are taking everything possible, so that their migraine goes away?
Right. So that's a good question, because as we discussed, as people get busy with their jobs and, have a family or have other, stresses in their life, usually migraine does get worse and it changes its form from an episodic to a chronic migraine. And then what usually ends up happening is individuals take medication for their headache acutely, usually over-the-counter medications, or prescribed, either way, but they keep taking them, say, 3 times a week and 4 times a week and 5 times a week. And once they get into that cycle, then they get something that is called as a rebound headache, meaning when they don't take these medications, the headache comes back and they have to take the medication to get rid of the headache. So it becomes kind of a really bad cycle. It is either called as rebound headache or a medication overuse headache. And once that happens, then we really have to move towards preventative therapy, because it is necessary to break that cycle of not getting into this chronic habit of taking over-the-counter medications to treat their migraine. So medication overuse headache is a very established thing, and it really needs to be managed appropriately because overuse of over-the-counter medications is also not advisable for various reasons.
Thank you so much for sharing that, Dr. Sathe. It's always important to, and that's why I always bring this point again and again, that as a common person, if you are not someone who is really acquainted with medical knowledge, it's always better to consult someone who has expertise in treating these conditions. And the information that we are sharing right now with our viewers is to enforce that idea that we have specialists such as you, Dr. Sathe, who can actually help and guide and navigate the management in such a way that maximum benefit is given to that patient in seeking treatment. When should a person become more concerned about this migraine and not take it lightly?
Well, in general, if the first and foremost thing is if they are requiring more and more medications to control the migraine, somebody who required, say, medication once a week or once in 2 weeks, and now all of a sudden is requiring medication more frequently, that should be the number one concern. Increasing frequency of headache is a big concern. Increasing intensity of headache is also a big concern. And most importantly, every person kind of knows their own character of headache. They know what their headache behaves like, the onset and how it gets worse. If there's a change in the character of headache, that is definitely a very important pointer to seek help for sure. So worsening frequency, worsening intensity, and change in character, those three things should make a person concerned.
And also any associated symptoms, say for example, medically, we know that any headache that is associated with severe nausea or severe vomiting, that should be paid attention to as fast as possible.
When you're talking about associated symptoms, I would also mention, a change in vision for sure. If there is any, say, change in mood or change in behavior associated with those headaches, for sure. If somebody has, say, any weakness in their arm or leg, or if they notice anything different about their functioning and is associated with the headache, that no questions asked, deserves medical attention.
Yeah, I think when you said about senses, where it's more about cognitive or a sense of hearing or vision or smell or taste, I believe if that has a significant change, then they should be paying attention to those symptoms too. Thank you so much, Dr. Sathe. And I would like you to summarize what would be the message to our community or viewers, especially about migraine.
Well, the message would be that if somebody has a mild migraine and they're managing it on their own and it's not causing them to have an interference with their activities of daily living or their life in general, sure, go ahead and take care of it, no problem. But as soon as you notice that the character changes or you're requiring more and more medication, I would advise them to seek medical attention and not really go into the cycle of a medication overuse headache. And preventative therapy for migraine does work. And it's always a risk benefit. But in many cases, you'll find that the benefit of taking a preventative medication usually outweighs the side effect that may be associated with it. But it also helps with not having to take pain medications all the time, which is a big benefit that not to be overlooked.
Thank you, Dr. Sathe. It was really very informative discussion. And I would say it's always such a great time for me when I'm having this discussion with you. Frankly, I learned something new today. It's always a great pleasure. And Dr. Sathe, you bring all your expertise and your experience and share it on Healthline for our viewers. So I want to thank you for your time and the information that you shared with us today. I hope to have many more discussions with you because migraine is just one type of headache. And I know that we will be talking about headache, which are other types of headache. I call it headache of headaches in our future episodes. So thank you so much.
So thank you, Varsha, and I thank Healthline TVAsia Telugu channel for having me. It was a pleasure to be here, and look forward to seeing you again.
Thank you, Dr. Sathe. Viewers, I hope you enjoyed today's episode on migraine and you learned something more about migraine. And actually, now you understand that migraine is not just a typical headache that anyone can have at any time. I really hope that you use this information um, to help yourself or your family or your friends, and continue to watch our show Healthline on TVAsia Telugu channel. This is your host Varsha Singh, who strives hard to bring you experienced experts and those speakers who can really give you wealthy and very important health information. Continue watching. Thank you so much.